AFT. Welcome to Brian Lehrer Live. Tonight, a special edition of our show, a full-hour debate on health insurance in America. Should the government or the market provide? This is a live debate that I moderated last week at the Harvard Club in Midtown, sponsored by the Manhattan Institute. You have on the right Dr. David Gratzer, a senior fellow at the Manhattan Institute and a physician from Canada who thinks the markets would do the best job in providing health insurance for the most Americans. And on the other side, Dr. Daniel Callahan, the director of the Hastings Center, a bioethics think tank in the Hudson Valley. He thinks the government is better to provide. Here are excerpts from that debate. Our guests have two very different backgrounds. Dr. David Gratzer might be called a Canadian dissident, which in the context of that country means he's very skeptical of their single-payer healthcare system. He is a physician, and he has this new book called The Cure: How Capitalism Can Save American Healthcare, published by Encounter Books. And Daniel Callahan is a bioethics leader in this country. He is co-founder and currently director of the international program at the Hastings Center in Garrison, New York. He has a PhD in philosophy from Harvard. And his latest book is this, Medicine and the Market: Equity versus Choice, published by the Johns Hopkins University Press. And so we're delighted to have these two thinkers who have both written major books on the topic, particularly of how markets and healthcare interact in this country. So, Dr. Callahan, you won the toss. So you go first.
I didn't see it, but okay. All right. Let me open up with a few appetizers, so to speak. One thing I've seen historically, which seems to me fascinating, is that when the United States feels it's having a healthcare crisis, we turn to government. We look to government, and we look to universal healthcare. When the Europeans, by contrast, have a crisis, as they've had over at least a couple of decades, they tend to look to the market. It's a very interesting exchange. In the mid-1990s, when we were having, with the Clinton plan was coming along, and a big push for universal health care at the same time, that was a great time for introducing market practices into the European healthcare systems. And so this is a peculiar irony. The second little tidbit is that no country, you should know, has an all government or an all market system. Every country has a mixture of some sort. And I think at least most healthcare economists would say the problem is getting the right balance. It's well to keep in mind in this country that 80% of healthcare costs, more or less, come from 20% of the population. Most of us are pretty well. The people who really get sick cost a huge amount of money, disproportionately large. However, about 60% of improvement in health in this country, life expectancy, a variety of other things, comes from background socioeconomic conditions, education, jobs, variety of other things, and not from formal medical care. And just within the past year or so, the U.S. has reached the 50% mark of government versus private care. Our percent coming from the government has increased very gradually and has reached 50%. And it seems to me, given the current debate, we're at a very important tipping point. Now, let me tell you my values for healthcare very rapidly. First of all, healthcare systems should have affordable access for all, and I take affordable access to be more important, morally speaking, and politically than choice. Above all, I think the system needs to provide economic security, since people not only can get physically well, but they can worry themselves sick about the cost of healthcare. The system should be efficient, it should have manageable cost, it should have simplicity, it should have good quality for the money, and there should be a system wherein there can be very good doctor-patient relationships. Now, I believe that if you look around the world, that the European universal healthcare systems are far superior to ours. You get better general health for less money, 50% lower annual cost inflation. They do provide universal coverage, so there are two types of system in Europe. One which is tax-based, which would be the United Kingdom, for instance, and Canada happens to be tax-based. The other is social health insurance, which consists of using private insurance companies, heavily government-regulated private insurance companies, and where the income comes from employer and employee contributions, but again, mandated universal care. Those countries have systems which are, in general, more popular than ours. The quality is equally good or better in many. I will say, since we have a Canadian here, that I consider the Canadian and UK systems the worst. I don't like to use the term the bottom feeders of universal care, but on the rankings, they've come somewhere between 14 and 16 in most international rankings of a variety of criteria. France, Sweden, Holland, Germany all do much better than either Canada or the UK. And finally, I would mention that while Canada and the UK have fairly long waiting lists, the majority of European countries do not, and where they do, they are fairly short. How do the European countries do so well? First of all, tight government regulation and control. There's no doubt that the governments run those systems. They are managed very tightly. They're very different, though. They're not a single one is like any other one. Some much more central management, others much more provincial or regional management. But overall, the government watches the whole system and takes care of it. And it seems to me that's not wrong unless you think government per se is wrong. But I will say that all of them, as I noted earlier, are prepared to use the market to improve the system. They see the market, however, as helping universal health care rather than competing with universal health care. And that, to me, is one of the remarkable features there. And now, in our country, I should mention that many commentators would consider our Veterans Administration, our Medicare program, to be very well run and efficient. And most people don't realize that the U.S. has the greatest life expectancy of people over the age of 80, all of whom are on Medicare, our government program. So what our own evidence in this country is that the government can do a very good job running healthcare systems. And I was recently at West Point, which is across the river from the Hastings Center, talking with the colonel we work with over there, and he said, the military healthcare system is just wonderful for me and my family. And he said, of course, it's a socialist medicine, but he said it really works. Okay, let's turn to the question, what is the market evidence? I think the evidence from around the world is very thin that market practices make any real differences. They are, for the most part, mainly speculative so far. They haven't been around very long. They've only been tried out in a few places. And where they have been investigated and tried out, sometimes they help things, sometimes they make things worse. But in no case do they dramatically improve or do they dramatically harm the system. Competition, which is a favorite of competition, is loved by market people. The evidence there is that competition, again, it works sometimes, it doesn't work. The places where it works best is where, interestingly, it is regulated by government. Left on its own, competition does not necessarily lead to lower cost or higher quality. In fact, very often, just the opposite. You get higher cost and lower quality because competition also means you have to compete not only on price, but also on services, amenities, and a variety of other things. Co-payments and deductibles, that's probably the most universal form of market practice everywhere used. It does make a difference, but usually a difference mainly with people in the lower category of healthcare spending. You're not much worried about co-payments if you're get in the hospital with a heart attack. Then it's big money, and even if you have catastrophic coverage, you're still likely to be in some trouble. Well, I think the worst problem is the problem of healthcare costs. Most of the discussion in this country has focused on universal healthcare, but I think our greatest problem is controlling healthcare costs, which are now running at an average of about 7% growth per year. Projected over 10, 15 years, you get horrendous figures which will bust the bank with Medicare and our healthcare system if that's not stopped. Now, to my mind, neither market practices in this country nor the government have done very well in controlling costs. That's why I say it's a much more serious and deeper problem. Certainly our Medicare program does a good job very generally, but its inflation inflationary move is pretty much the same as the private sector. So that's our common problem, and and interestingly, most of the healthcare proposals out there, if you look at them carefully, don't say much at all about controlling costs. It seems to be one of those hot rail type things they don't want to go near. So my own conclusion is, I guess I want to say finally, that I don't understand the romance of the market. I started reading the Wall Street Journal and Forbes and other magazines when I bought mutual funds. Then I got interested in the healthcare and started reading the editorials of the Wall Street Journal. And of course, the Wall Street Journal editorials love the market. But the antidote to the editorials is reading the news in the paper there, the same newspaper. From what I can see, the private sector incredibly screws up all the time. I don't think the federal government can possibly do worse than, say, General Motors or Ford, much less Enron and a variety of others. The papers are full of screw-ups, foul-ups, messes, scandals. So it's hard for me to, at least, to fall in love with the market. The market seems to be interesting and nice and probably have some good if you want to raise the general level of society economically, but in trying to apply it to a healthcare system, it seems to be simply does not work and will not work. There is, in the end, no real accountability in the private sector, and that, to me, is the problem. I like government because there is public accountability, which there is not in the private sector. I want to let Adam Smith...
One more minute.
One more minute. I want to let Adam Smith have the last word. Adam Smith really wrote he was the founding father of market theory in the 18th century. This book, The Wealth of Nations, and he wrote a famous passage. It is not from the benevolence of the butcher, the brewer, or the baker that we expect our dinner, but from the regard for their own interest. We address ourselves not to their humanity, but to their self-love, and never talk to them of our own necessities, but to their advantages. Nobody but a beggar chooses to depend chiefly upon the benevolence of his fellow citizens. Now, I guess I would want to add to Smith's list, along with the butcher, the brewer, and the baker, the health insurer and the drug and device manufacturer. I would much prefer a well-regulated universal care system accountable to the public and not to the vagaries of competition or to profit-driven enterprise. Profit-driven enterprise is terrific from commuters for most things, but it seems to me it's a very mischief-making factor in healthcare, even though it brings many benefits in many ways, but on balance, not enough benefits and too much harm.
Thank you, Dr. Callahan. Dr. Greatson.
Thank you very much. Thank all of you for coming out tonight. I think it's a really interesting topic and certainly a very timely topic. It's also a very personal topic, and maybe rather than open by quoting Smith, I'm not an economist, so I don't tend to quote Smith, or quoting somebody more august, let me just talk about a personal story with regard to healthcare. Some of you have heard me tell this story before. In fact, I think Larry Moan has heard me tell this story no less than 5 separate times, which is why he's the president of the Manhattan Institute and the therapist-in-chief, even though I'm the only psychiatrist on staff. It was the best of American medicine. It was the worst of American healthcare. You see, my wife had a procedure done. It was a half-inch incision, 30 minutes in the OR, and it generated a bill that was 1.5 feet long. That was my wife's experience with neurosurgery. See, this was supposed to be the least expensive vacation of our lives. I was invited to a speech out in the Rockies, and I'm a prairie kid. Being invited out to the Rockies is very compelling. The tickets were paid for. The hotel was paid for. All I needed to do was buy the lift tickets, enroll my wife in the ski class, which, as I recall, was called the Snoopy Easy Ski Class. And we were off on vacation. Things didn't quite work out for us. My wife tells this story slightly differently than I do. She tells the story of a mountain, gale-like winds approaching 70 miles per hour, and maybe a small mammal, a squirrel or something, the sort, culminating in a gigantic fall. I seem to recall this as being a terrible accident on a bunny hill. Whether or not you accept her godly version of events or my perhaps Greek godly version of events, the long and the short of it was this. My wife ruptured a vertebra in her back, ruptured a disc in her back. She needed neurosurgery. My wife's a family doctor. She works in emergency rooms. She's an unusually active person. She would spend 4 or 5 hours a day because of the pain, just lying in bed, hoping the pain would subside. Well, it turns out that there's one procedure that can be done, discectomy, which is enormously commonplace and enormously effective. A half-inch incision. 50 years ago, there was no such procedure. 30 years ago, probably would have been a 4 or 5 inch incision. But today, just a little keyhole incision. She got the procedure done. She's doing well. We're expecting our second child in May. Life is good. That is the best of American medicine. But the flip side is, of course, our horrors of just trying to access that. At the time, we were uninsured. We looked in West New York first for a neurosurgeon, so we went to the internet, we Googled neurosurgery New York. We got lots of colorful hits, most pornographic, some trying to sell us cheap drugs from Canada, but very little relevant information. I'm sure you've had the same experience. I called neurologists because if you want an opinion on a neurosurgeon, you should call neurologists, right? Because they don't cut people. And I would call these people I had never met before and ask them their surgical opinion on a colleague. Needless to say, I didn't get a lot of information. Finally, the long and the short of it is we found a surgeon we liked, and he offered us a choice of 2 hospitals to have this procedure done in. We went back to the internet, found no quality data on either. We eventually chose a hospital with Saint in the title, reasoning that, you know, nothing bad can happen to you in a hospital with Saint in the title. It generated this enormous bill, which, as a doctor, my professional opinion was it was absolutely and completely inscrutable. It was for an enormous sum of money. We talked to the hospital administrator, who explained to us right off the get-go not to worry, this is just a starting point of negotiations. Where else in the American economy do you get sent a bill and they tell you right off the bat, not even we take this bill seriously? I eventually went back to them and suggested I would pay list price of Medicare plus 15%, and she responded, no, she can't give me the list price of Medicare. I said, why? She said, it's a secret. Everyone I know has some sort of a story like that. The ever-rising costs with American medicine, the lack of transparency, the fact that, like we did, you could pick a hotel in Buffalo and get great quality data, but try and pick a hospital in Buffalo or New York or Los Angeles or fill-in-the-blank city, and you're stuck. There are a couple of lessons I think you can draw from the story. The first is, don't forget the good with American medicine. Okay? What we've experienced in the last 60 years, the rise of modern medicine, not the last 6,000 years, not the last 600 years, but the last 60 years, has been truly remarkable. My wife literally got off from the bed and resumed her life after that procedure. And all of us could tell stories of medical miracles. I know that word is a little bit overused, but it is appropriate. Death by cardiac disease has fallen by 2/3 in the last 50 years. Polio has been confined to the history books. Childhood leukemia, which was a death sentence for any child 12 and under, just a short time ago, is eminently treatable. Say what you want about quality with American medicine, but don't forget the entrepreneurship and the innovation we've seen and the miracles it has produced. All of those developments, by the way, were American developments. And just to emphasize how much occurs right here in the United States, Health Affairs asked about 5 or 6 years ago to rate the top medical developments of the 20th century. 8 of the top 10 occurred in the United States. And as we've seen, pharmaceutical and biotech developments become more and more American, even if the companies are not. We'll continue to see that. So there's much good here. But why is it that there's so much problematic? Why is it there's that cost issue, as an example? And on this issue, Dr. Callahan and I would thoroughly agree, if perhaps not on much else. There is a cost crisis in America. And I think the traditional answer you get when you talk to economists or health policy people is, hey, medicine's better than it's ever been before. Of course it costs more money, right? Dick Cheney, whether you love him or hate him, has had 4 heart attacks, and yet he's able to hold down full-time employment and walk up a flight of stairs. What medical innovation that has been to create that scenario. And the corollary is it costs a lot. The implantable pacemaker in his chest costs about $30,000, or to put numbers at play, about 50 times more than the per capita spending on average of the American when Marcus Welby, MD, was the most popular show in America, and 1/3 of American families tuned in every week. So there's been this huge explosion on the innovation side. The flip side is, hey, just have to pay more. And that's the way I used to think about things. But the funny thing is, when you look at every other aspect of the economy, you don't find that. I mean, let me just ask a quick question on unit cost. Does anyone here have a computer? Oh, Betsy has a computer. Did he have a computer 10 years ago? Absolutely. Is your computer today vastly superior to your computer 10 years ago? You can email faster. You can communicate with friends faster. If you're so inclined, you can download naughty pictures from the internet faster. There you go. That's very revealing. If a little bit of a setup. Cost of computers is down. Cost of agriculture, relatively speaking, is down. Cost of much of everything is down, except healthcare. If one were to look at GDP spending on healthcare in 1970 in contrast today, it's roughly doubled. Now, Some people say that's just, because healthcare is a little bit different. I don't accept that. I think, in fact, if you look at certain aspects of healthcare, you find cost does drop with time. LASIK eye surgery is one example. Today, the procedures are 30% cheaper than they were just 10 years ago. They're infinitely better. The satisfaction rates, by the way, best anything you'll find in the public sector or the private sector. There's just a study by the group at the Study for Health Systems Change that showed 95% satisfaction rate. This, by the way, wasn't a group particularly sympathetic to the private sector. Why is it healthcare is so different? And I would argue we pay for it so differently, both in the private sector and in the public sector. Everything really ties back to 2 days. 2 days, almost 6 decades ago. In fact, more than 6 decades ago. October 26, 1943, December 1, 1942. Days so important you would think, my goodness, the President must have given an important speech or Congress must have passed important legislation. In fact, these are accidental dates. October 26, 1943, an IRS ruling. December 1, 1942, a report issued in Britain. And yet, those are the dates that change American healthcare. October 26, 1943, a minute of explanation, is when the IRS ruled that health insurance premiums could continue to be paid in pre-tax dollars. It's a result of wage and price controls that employers got in this game in the first place. They couldn't offer employees better compensation, wage controls, so they started to offer health insurance. Previous to that, employers weren't in this game. Suddenly it made sense to do so. December 1, 1942, Lord Beveridge releases his report in Britain about the welfare state in Britain and calls for $0 health insurance to cover the British people. Lord Beveridge is an enormously charming individual, as British and British colonial subjects often are, and he toured the United States, and he really impressed people in FDR's administration, the Truman's administration, and laid the intellectual foundation for Medicare and Medicaid. And the end result of those 2 days is whether you're covered in the private sector, employer-sponsored health insurance for the most part, or you're covered in the public sector, usually Medicare or Medicaid, or I suppose to a lesser extent, VA. You're overinsured. What do I mean by that? For every dollar spent in the United States, we spend about 14 cents out of pocket, which means when you go to your doctor, or you go to the hospital, or you're told you need an MRI, you don't, for the most part, ask about cost because somebody else is paying. And historically, we've evolved into a system heavy in cost. Again, my colleague and I would agree on this, but relatively light in terms of quality data and ultimately satisfaction. I think that is an economic problem. It is not a problem that relates to our ability to organize healthcare. It is not a problem that relates to our doctors not being motivated or nurses not being talented enough. It's an economic problem. And an economic problem needs an economic solution. We need to move decisions back to the individual. We need to get around 60 years of health regulation. We need to reform Medicaid the way we reformed welfare reform, by experimenting and evolving to the states. We need to look at the size and cost of the FDA, because that's what's influencing the cost of prescription drugs. Am I saying that we shouldn't have any role for government? Of course not. But I'm saying in every other aspect of the economy, the other 5/6 of the general economy, costs fall with time, satisfaction rises. Why is healthcare so different? Well, we probably disagree, but I would argue we simply pay for it differently, and that is what we have to change. Or, to use slightly different terminology, we need a strong dose of capitalism.
Thank you very much. 5 minutes.
The question that's troubled me for a number of years is how much is enough? I certainly agree that the U.S. has made major contributions. We've benefited enormously from the technology. It has saved the lives, I'm sure, of many people in the room. But how far can you go? It seems we have reached a point, particularly with the technological innovation and progress, that we're getting a bad economic fallout. Much as we've gotten a bad economic fallout when the number of automobiles gets more and more and more, and the highways get higher and higher. Automobiles are wonderful. Their price has gone down, but you spend a lot of time in traffic jams these days as a consequence. So I think the fundamental question is, when do you stop? Do you want to keep growing indefinitely, in which case you can't afford to do that? So the fundamental, how much good health do you need in order to live a pretty decent life without having continued infinite technological innovation? I think we have a comparable problem with global warming. That is to say, we've all enjoyed the benefits of industrialism, of enormous amount of capital invested in all sorts of non-medical technologies, and the net result is we're polluting our planet. We have, it's very interesting, the same day as that we've been worried about the U.S. healthcare system, we get the very fundamental scientific report that the global warming is a serious problem. And it's very interesting. In both cases, it's that we've had too much of a good thing, and that seems to be our subtle problem. I think the issue of unit cost down is very misleading, because in healthcare, when the unit costs go down, the number of users increases. With the exception of drug companies who don't use economy of scale, they don't reduce their price until, as long as they're on patent, you'll notice. But other devices go down. But by and large, when unit costs go down, you can be sure that the aggregate cost of the technology will go up. And that's our problem. It's the aggregate cost, not individual cost. Moreover, since there are more things we can do these days, the number of individuals and scans and screenings and diagnostic procedures, we all get many more than we would have 30 years ago. All of the individual things are cheaper, but the cost of them together is far higher. The ironic part of this, in this country, I think, is the healthier we become, the more we spend on healthcare. This isn't a situation where we decide, my guys, we're healthy enough, let's slow down. No, the healthier we get, the more we get, in great part because as the technology advances, we raise the baseline of what we want to count as good health. We demand more on the way of health than people did 30, 40 years ago, and that's part of our problem too. How do we reduce the excessive demand? Finally, I would note that the European healthcare system, particularly the social health systems, do have a large segment of employer-mandated contributions, much as our situation. So it's not that this, yes, we have a unique history of why we got it, but a majority of European countries have the same thing, and it doesn't seem to have ruined them.
Dr. Gates?
I appreciate the siren song of universal healthcare systems. We hear these debates all the time. I think you've put forward a nice argument for it, both in person and in your book. And by the way, I have the utmost respect for the tremendous research involved in your book. Certainly one can read, people make such arguments all the time. One gets more for less. Everyone is covered. People are more satisfied, yet health costs are lower. Doesn't that sound so compelling? I used to believe that too. I was born and raised in Canada, in a little town called Winnipeg, smack dab in the middle of the Canadian Prairie. Look, when I was a teenager, I don't want to overstate the case, I hadn't spent a lot of time thinking about health economics. I wanted to get into med school. I could quote you statistics on MCAT scores and admission rates. I wasn't an expert on GDP spending. I guess I soaked up three things from the Canadian environment. One was a love of ice hockey. Two is an ability to convert Celsius into Fahrenheit, and the third was a belief that if government did it, when it came to healthcare, it was compassionate. I started to change my mind one very frosty morning in Winnipeg when it was 40 below, which for you trivia buffs is actually the same in Celsius as it is in Fahrenheit, and I decided to shave 2 minutes off my commute into the classroom, and thus I learned my most important lesson in med school on the way to the classroom, not in the classroom. And I walked into an emergency department, and I swung open the door, and it was littered, literally, with people, some having waited up to 5 days, and the smell of urine and of sweat and of fear hung in the air. And what I discovered then was Canadian healthcare actually isn't so compassionate. Now, it's easy to try and distance public systems from the Canadian experience. I suppose part of the motivation for that is, Canadians speak English. It's easy to find the horror stories, and there are a lot of them. Just as an example, one of the most fashionable things to do in Canada is to get the healthcare you need in another country and then sue the Canadian government for it. Suzanne O'Corn would be perhaps the most prominent example. She's a woman with stage 4 metastatic colon cancer who just needed a trial of Erbitux. She found it in Buffalo, New York, and sued the Canadian government, who turned around and responded that Erbitux was unfounded and unproven. Actually, it has been. It's FDA approved. And also she went to an unaccredited facility. She went to a cancer clinic, not in Tijuana, but affiliated with a Catholic hospital in New York State. That is what goes on in Canada. Hundreds of thousands of people wait for some type of care. 1.2 million people, not my statistics, the government statistics, are actively looking for a family doctor and can't find one. Is that experience so terribly different from what you find in other countries, as you've suggested? What about the social insurance countries? Well, I think it's pretty much the same all across Western Europe. I mean, Britain, more than 1 million people are waiting for some type of health care. There's recent stories about a woman who has breast cancer who had her appointment with an oncologist canceled 48 times in a row. In Western Europe, again, one sees similar things. Look at France. 13,000 people died of dehydration largely 2 years ago because French doctors go on vacation and many hospitals aren't air-conditioned. Beware the soft bigotry of low expectations. I think there is that compelling argument about universal systems. I would make several arguments about them. First of all, the quality data is not there. If you judge things by life expectancy, as one example, you're being sorely mistaken. Life expectancy is a crude indicator of health. Crude indicators are just that. Crude. There's a very smart analysis in a new book that just came out. Paul recommended it to me, called The Business of Health, where they looked at ways people, influences on life expectancy. One is, of course, accidents, another is murder. That has an influence on statistics because Americans, as one example, are 8 times more likely to be murdered than a person in France. If you exclude accidents, primarily traffic accidents, and you exclude violent death, one finds that American life expectancy actually is longer than those of our compatriots in Canada and Western Europe. Again, I'm not arguing one should hang one's hat on those statistics. What I am saying is you have to be careful about it. What I think the way you measure a healthcare system is you do look at what happens when people get sick. I talk about that in my book. I mean, breast cancer, people are diagnosed 4 times more frequently in later stages in Europe than they are in the United States. Comparing outcomes, one finds that the outcomes are substantively better. I'll quote you WHO statistics. Leukemia, American survival rate 50%, European rate 35%, esophageal carcinoma 12% in the US, 6%. Across the Atlantic. And I could quote you studies on heart disease and so on. I'm not for a minute arguing that there aren't problems with American healthcare. Goodness, I've just written an entire book talking about the problems of American healthcare. But when you look to a solution, find a solution that's appropriate. I think what we have here is an economic problem, which we don't have in the other 5/6 of the economy. Fix that through competition, through individual choice, and like in the other 5/6 of the economy, costs will fall, satisfaction will rise. That's the prescription for American healthcare.
Okay, let's pick up right there. Dr. Gracher just mentioned some specific outcomes in Europe that are worse than in the United States. How late people get diagnosed with certain illnesses, leukemia survival rates, things like that. You said before, Dr. Callahan, that in general Europe has much better efficiency and better outcomes than the United States. Do you want to talk about examples as you see them?
I guess my best example would be heart disease. We do much worse than the Europeans in treating heart disease. Cancer we do very well on, but cancer has always been special in this country. A recent public opinion survey found that the majority of people think cancer is the leading cause of death and the worst death, whereas in fact heart disease is the leading cause of death. The European countries do better on heart disease, worse on cancer. But this is true of a lot of things. We're better on some, they're better on some. And I think as one study even cited it in Dr. Gracher in your book, said it all depends. You can't even readily generalize too much about the country. But I would again go back to my original point that the European healthcare systems are all different. Canada and the UK don't count for me very much. They are comparatively lousy systems, but others are far better, and that should be said. And the fact that we lead on cancer is not surprising. It was the first institute, part of our institute, of the National Institutes of Health. It's always been a kind of specialty in this country, the real big dread disease, which I think is less true elsewhere.
Let me follow up, because if we do cancer better and they do heart disease better, assuming that's true, and we have these disparate systems, then are the systems the reason in either case?
Well, I think culture is probably the reason, because what's very striking in Europe is the health systems are very much influenced by the type of culture they're in. It used to be joked that the French thought the liver was the big troublemaker in the body. And I think in this country, cancer has been the big troublemaker. People have different versions of what's good or bad diseases. I spent some time in the Czech Republic. A lot of them don't think Alzheimer's is even a disease. People just get older, they get senile, I'm told there. So I think culture is really explains an awful lot. People have different upbringings, they have different religious traditions.
But then how instructive is that in terms of what kind of a healthcare system?
One of our problems, the problem is if you try to think about our healthcare system has an analogous problem. So Dr. Wenberg at Dartmouth has shown enormous disparities across this country in the cost of treatment and the level of treatment, just incredible disparities. And this suggests that a problem for any healthcare system, internally here, the problem is how can we get a more uniform level of care instead of having sometimes 2 or 3 magnitude differences. That's one of our special problems, which neither left nor right seems to have any good answer to.
Dr. Greatzer, do you make any of the distinctions that he makes between non-U.S. Western healthcare systems? He puts Canada and the U.K. at the bottom, he said, but France does much better, Sweden does much better with government-controlled healthcare. Have you compared any of those?
Look, I think international comparisons are difficult, but I actually don't find there's that much of a difference between these systems, except, as I said before, you can call up a Canadian, you can hear a horror story. It's more difficult to do that with somebody in Sweden. I think when you look at public systems, what you find is that government is very intrusive. Whether it's a single-payer system where literally the government pays every bill, or it's a German-style system where the government isn't directly the insurer but kind of is. Because you find in all of those systems, governments pay huge sums of money. In Germany, as one example, 75% of the cost of all prescription drugs come from the public purse, and as a result, the government tries to figure out a way to temper costs. Part of that is a democratic reason. There are a lot more healthy people than there are sick people, so the government has an incentive not to spend too much on the sick. And what you find is standards are very different. I've pointed out cancer outcomes. My reading, the heart literature, is actually quite different than my colleagues. As one example, a year after a heart attack, 55% of Americans actually feel better. 40% of Canadians feel better, which for those of you kind of snoozing at the back might suggest that we should have a heart attack as part of some sort of a miracle diet. But that's not what I'm saying. What I'm saying is with the technology and access to technology that you have in the United States that you don't see in public systems, people do get better. You raise Alzheimer. I think that's a classic example. If you have Alzheimer in America, you'll probably go on Aricept or one of the cognitive enhancers. I would point out, as an example, in Germany they don't publicly pay for that. Why? Government doesn't think it's worthwhile. If it was my father, I think I would think it worthwhile.
And nor do most geriatricians in this country think it's worthwhile either. They think it's basically useless.
Well, actually, I am a psychiatrist, and I do spend part of my time treating the demented. And I would point out that the studies do suggest a slowing in the Alzheimer process, so it's not really a cognitive enhancer. But, you know, again, I think it's better than doing nothing, which is what would happen to you in Western Europe. I'm not suggesting that we can look at this as a black and white issue. You're quite right. Wenberg's data suggests huge inconsistencies in the United States, huge differences in quality and expenditure. But I am saying that before we run off to a single-payer system, before we dismiss the private sector, let's look at what's good and let's look at the rest of the economy and the lessons one can draw.
So let me get you to respond to some of that specifically. Dr. Greatzer told the story of his wife needing neurosurgery after a skiing accident of undetermined cause. And the moral of the story was, don't forget what's good in American medicine. Entrepreneurship leads to innovation. And he ticked off all these things that have come from the U.S. system and said basically that it's because we have more entrepreneurship in our medicine that these advances come to be available to his wife and other people. How much of that do you disagree with?
Certainly everybody gets more than they did before. What I think is absolutely agreed upon by economists is that 40 to 50% of our annual growth in healthcare costs can be traced to either new technologies or intensified use of old technologies. And it is that 50% which then is heavily responsible for the fact that we have an increasing number of uninsured, that we have an increasing number of companies dropping healthcare benefits altogether or cutting those benefits. And it seems to me that the ultimate problem gets back to the use of technology, which is the main driver of cost. And this is true in Europe as well as here. And that's the one that I think the European countries do much better on because they're prepared to be tougher. Competition, basically, I don't think it works anywhere. I'd love to see a nationwide example of it making any big difference other than 2 or 3 percentage points. As far as patient choice is concerned, well, I just had a recent adventure with spread prostate cancer, and you males know what fun that one is. And I got all the experts and had a lot of choice and everything. In the end, I just had to depend upon my doctor because it was all too damn confusing. And if I'd had to have an operation, I would have gone into a hospital, which would have been very difficult for me to assess just how well they do on prostate surgery anyway. And even if I'd known, it probably still would have been difficult. So I find the technology very difficult actually to use. So I don't believe very much in consumer-directed healthcare except for trivial things. I've been in the emergency room 4 times over the past 3 years. And not once would I've had any opportunity to select an emergency room based on economic or other criteria. You go to the nearest one. And if you're old and you get multi-organ failure, then it's going to be very hard to assess who really does multi-organ failure very well and try to assess that. Most people are going to do what their doctor tells them, and that's why the whole notion of doctor-patient trust is very important. And there's no doubt that commercialism is one of the enemies of a solid doctor-patient relationship.
But let me follow up on innovation. Were you saying, forgive me if I misunderstood,
No.
were you saying that there's too much innovation, or our system produces, emphasizes
Well,
innovation at the expense of other things?
Yes, it certainly, the emphasis is very heavily on technological advancement rather than long-term care, rather than ordinary caring, home care, variety of other things that people need, particularly as they get old. The problem is that the progress in health is going up like this, the costs are going up like that. It's that gap that's grown between our gross domestic growth of our gross domestic product on the one hand and our healthcare costs on the other, and that gap now is around 3 to 4% a year, which is just a very bad gap altogether.
So you would rather have more treatment with today's
Well,
technology, even at the cost of less innovation?
Oh, absolutely. If everybody got even what we had 5 years ago, they would live very longer lives than anybody in the history of the human race, and that seems to me pretty good.
So, Dr. Greatzer, what about that as a proposition?
Depends on what the definition of is. Look, I think, look, just to touch on prostate cancer and outcomes, I would point out in the United States, for people diagnosed with prostate cancer who succumb to the illness, I'm not going to make this personal, obviously, but just talking about gross statistics. Under 18% of Americans who are diagnosed succumb to the illness. In Canada, it's 30%. In Germany, it's about 35%. In France, it's 45%. These are Commonwealth Fund study statistics. These aren't my statistics. Be careful what you wish for. What do I think is going on with technology? Well, maybe actually we do agree on something here, and that's the following. Maybe Americans are overly zealous in what they get when it comes to healthcare. Maybe we rush off to new technologies too quickly. But of course we do. I mean, we're paying 14 cents on the dollar. Of course, if your doctor turns to you and says, I think it's just a stress headache, but we could have an MRI to make sure, or a CAT scan, or an X-ray, you're going to choose the Cadillac, because for the most part, somebody else is paying. Does that mean that we can't have new technology in the United States? Absolutely. But I think part of the problem that goes on in the United States, and Wenberg's statistics, which you brought up before, illustrate it well, is that we've got such a buyer's market, which is, to go back to Wenberg's statistics, why people in Florida on Medicare cost about twice as much to the taxpayer's purse as the people in Minneapolis, and yet there's no difference in health outcomes. That doesn't strike me, though, as a failing of the market. I think the market's working splendidly. It's that the market is so disturbed and so distorted with subsidies that, I mean, just imagine if you paid 14 cents on every dollar, or better yet, your employer paid 86 cents on every dollar when you went to the grocery store. Who would leave with an empty cart? So I think that what we have to address is the economic problem, and then I think what you're going to see is that technology is going to be used a little bit more shrewdly and a little bit more appropriately. I think today we have a buyer's market for new technology. I think in the future we should have more of a market for healthcare quality, and that's only going to rise when people are more focused on these things. My colleagues suggest you can't have a market because we end up in the emergency department. I mean, there's some truth in that, but the majority of people who have contact with healthcare, aren't people having contact like it is in the show ER, where you're bleeding profusely after the tractor-trailer accident on the highway. Most of us have contact with healthcare in terms of primary care provision, or we need a procedure done. All of those things I think we could shop around for. There are limits to that. Mind you, most of us don't really shop around that much for other things. It's about 10 to 15% of the market that shops around, as my colleague Regina Herzlinger likes to point out, and the rest of us piggyback off of it, right? I mean, how many of us actually read Consumer Report magazine? Their subscription rates are about 15,000. Considering every public library in America seems to subscribe to Consumer Report magazine, suggests to me practically none of the rest of us do. But my neighbor does. And when my neighbor bought a Toyota, I knew Toyota was a good car for me as well. And I think that's what we'll see more and more of in healthcare, when people have more of a vested interest, not just in getting care, but in also costing out the care and asking tough questions.
Can I ask you where access to insurance comes into that? We haven't really spoken at all yet about the uninsured in this country, and probably most uninsured people would argue that it's not a buyer's market for coverage.
Right.
So where does that come in for you?
Look, I mean, part of this is well, the uninsured. It's a complex topic, as you know. We've talked about that before. People see the uninsured as being a homogeneous group, kind of like people walking off the set of Les Miserables who can't afford care, the single mom on the show ER who walks in and she can't afford any coverage. Now, she's probably on Medicaid. Her neighbors are probably on Medicaid. Of the uninsured in the United States, a third of income is $50,000 or more a year. A third already qualify for Medicaid. But about a third are the working poor. About half of them will have insurance within a year. That's kind of the turnover one sees with an employer-based system. You lose your job, you lose your coverage. But there is that core group, about 8-9 million, who fall through the cracks. What do I think ought to be done to help them out? Well, I think, first of all, if we got the cost side of healthcare a little bit more appropriate, if we had more innovation and more choice, I think costs actually would fall with time. I think that would help make it more accessible. What about the rest of them? Of course there's a role for government. Right now, we have a huge role already for government. 50 cents roughly on every dollar spent on healthcare in the United States is directly from the federal or state treasury. I just think it's unfocused. I mean, a great example of that would be how we help the uninsured. Right now, we help the uninsured by funding hospitals. I don't think that makes much sense. I like President Bush's proposal, where he would turn the money over to the states and let them experiment. New York State wants to fund a bunch of hospitals. That's great. But if New York State or Arizona, where I was yesterday, or North Carolina, where I also was yesterday. I've had a lot of travel with this storm. If those states want to say, come up with a voucher system for private insurance, I think that's a reasonable approach too. I think one of the basic problems we have in America is there's not enough innovation and experimentation when it comes to healthcare. I don't know what the right answer is, but this is a classic example where we spend a lot of money, about $60 billion a year in uncompensated care, and the results really don't reflect that.
So arguably, if we take steps to cover everybody through more government subsidy or whatever, then that's not going to reduce the demand, and so the inflation will continue. So how do you solve that problem?
You get mean-spirited. You basically tell people, we're not going to cover this. We have a new technology that comes along. It'll cost $100,000, but it'll only give you 6 months of life. That will not be covered. Medicare now, interestingly, is not allowed to take cost into consideration in making their reimbursement judgments. And they basically have to decide what they will pay for, and what they decide influences the private care system as well, but Medicare cannot consider cost. This has been there from the beginning. It's there in great part because the device manufacturers don't want cost considered, but that seems to be the first step with the government program, which we could do, is to say, by God, we are going to do cost-benefit analysis.
So you want Medicare to more explicitly ration?
Oh, absolutely, it should. And I would say that if Medicare, anybody in the industry would not like this, I would say that every time there is a new drug to be coming out, that not only should safety and efficacy be measured, but there should be an economic impact statement. This thing will cost X amount of money, and it will cost the system Y amount of money. And we do that with every new technology, and it's not allowed out until the manufacturers have given us good, solid, reliable data on what that economic impact will be. Now, what happens is the new technologies are invented, they're wonderful, but they're sort of thrown out the window, and then we're all left to fend for ourselves and finding a way to deal with the costs.
So I'm curious, do we have common ground on that point?
No. Not even close. I tell you what, this is the common ground we could find. I'm willing to say to a 90-year-old person, your life isn't worth living. We just won't give you the technology, which is sort of a blunt way of rephrasing what you've just said. But before I'm willing to do that, I want to experiment with market reforms. I want to say, look, let's try and get the market working right. Let's say if we can avoid the rationing that you endorse that we see in Western Europe that causes cancer outcomes, amongst other things, not to be as robust as they are here. But before we do that, let's see if we can actually instill some market forces. And if we can't, and if the costs are unsustainable, hey, then I'll become a socialist too.
Well, is one of the underlying questions here, and one that the American people probably don't have to grapple with enough, this: we are going to ration health care. We are rationing health care. And as technology continues to explode and, the potential treatments out there become more and more and potentially cost more and more, rationing is going to be a fact of life. And so the question is, who rations? The market or the government or something else? Is that a useful way to frame the question?
I think that, as I've said before, in every other sector of the economy, prices fall with time, costs fall with time. And I would say that probably you would see the same thing with healthcare. So I don't think necessarily we need to make those horrendous decisions.
The market does ration today, does it not?
Well, I suppose by price. But in America, no one goes without food except perhaps a very small number of people and the mentally ill. One sees, again, there isn't a crisis in clothing, right? One walks down Fifth Avenue or one walks through Soho, and for the most part, people are dressed. Sometimes they're not dressed in the best of fashions, but look at me, I'm a more traditional gentleman. So what am I suggesting? I'm saying that we can accommodate food, clothing, shelter without saying a 90-year-old person shouldn't get food because it's too expensive, or a 90-year-old person shouldn't get shelter. What we do say is we say let's let the market sort things out for the vast majority of people, and for a small number of people we'll turn it over to government. That's the approach we ought to take with healthcare.
Can you address the rationing question, and do you see the market rationing in the way that he does, or not rationing so? And I guess he's saying ultimately people get the care they need, more or less.
When I look at the market, I break it down into the components I mentioned: competition, choice, the assorted market techniques that are supposed to do the job. Most of them have not been thoroughly tested in any national scene. Almost none of them will make much difference at all on cost. Even to have an experiment is difficult because you've got to be willing to do it over a long period of time, and you've got to be willing to have it turn out badly. I would actually favor experiments, but I think they're going to be enormously difficult to carry out. The only way to carry them out is to have the government run the whole experiment. If you just say, well, we take the market's left on its own, it'll sort itself out. Well, I wouldn't believe that for a minute. It'd be insane to believe that.
But I don't want to get off rationing quite yet, because your system has the government saying to that 90-year-old, your life isn't worth living, as he interpreted what you said, and he's saying it's a better way to ration to have the market do it by price.
Well, price is a terrible way to ration, because then you obviously get the bias of those with money can buy it and those with money can't buy it. If you have a lot of money, you buy the best. If you have poor money, I think what you say to the elderly person, I think what we're going to have to do is in effect something whereby we will have to devise some measure, but we have a measure now called quality adjusted life years, which is an effort to measure the impact of a particular technology by asking how many years of extra life will it give at what quality. And it seems to me with the 90-year-old, with a very expensive treatment, what you might say is that your quality figure is a very low figure. There are other things in our healthcare system that seem to us comparatively more important. Your life is valuable to us. On the other hand, we have children, we have adults with families, and we can't give everybody everything, and at some point we draw the line, and it seems to me at 90 years old is not a bad place to draw the line. I'm 76, I've been saying this for 30 years. People say, why did you get old? Well, all the more reason I watch people get old, and it's not a bad way to do things.
The audience is wowing, are you?
I think he provided the best rebuttal to his own point.
You see, nobody wants to consider things that might actually work and would really deal with the problem.
No, I'm
they
willing
want
to
wiggle and squirm and do experiments. And, well, my gosh, we've experimented. The whole European systems, that's a big experiment that's going on 100 years. We can look at that experiment.
I have looked at that experiment. We drew, and you did too. We just drew different conclusions.
Well, no. Yeah, I said it turned out terrifically.
Well, unless you have cancer. Again, I can't help but feel that we have to look at what works in the United States. 5/6 of the economy, prices fall with time, quality rises. Look at another basic need like food. I mean, in the United States, costs have fallen so much with regard to food that we actually have a crisis of obesity. Food is arguably too cheap. Now, I'm not arguing for a Twinkie tax. I'll leave that to really smart people to figure this stuff out. But it just strikes me that healthcare is different just simply because we pay for it differently. Now, again, I'm not totally immutable to being persuaded on rationing, and you've encapsulated your own argument perfectly on that point. But before we turn to the 90-year-old and say, your life is important but tough, I would turn around and I would say, look, let's instill more market forces in the American healthcare system, and let's see what happens. My suspicion is you'd see a lot more examples like you see with LASIK eye surgery, where costs fall with time and quality rises. And I think the problem with American healthcare is we don't do enough of that. And that's the approach we ought to take. That we do have many experimentations, by the way. It's not all bad news. As I pointed out in the Wall Street Journal a couple weeks ago, we've had 3 years worth of data, as an example, with consumer-driven healthcare. I would never suggest that this was perfect. I would never suggest that one can draw definitive conclusions on 3 years worth of data. But you look at insurers like Aetna, and they point out that people in HSA and HRA plans, their costs have actually risen 3% over 3 years, not compounded annually. Just 3% in total. That strikes me as an experiment that's worth doing. Devolve decisions down to the individuals. Will we ultimately have to make rationing decisions in Medicare and Medicaid? I remain unconvinced, but even if I were convinced, I would still say, why not try market forces with the vast majority of American healthcare? Why not deregulate? Why not instill more competition?
Fine, I would say let's install universal health care and then experiment with markets within that system, as the Europeans, I think, do quite successfully, and they get a good balance that way. And let me get back to the unit cost. That's true, unit cost drop, but the aggregate cost to the system increases because the unit cost drop. Dialysis system, historically great example. Dialysis was very expensive in the early 1970s when it first came in. The number of users was in the tens of thousands only. The cost came radically down, and now the number of users is in the millions. And the overall price of treating dialysis is far higher now than it was then, because the unit costs are lower.
It's not, well, or more people benefit, but it's actually not necessarily true, though, that unit costs fall with time. You cite dialysis. Let me give you an example from cardiac care. As you know, David Cutler spent a lot of time analyzing this. He had a very nice article in the New England Journal of Medicine. I don't agree with all of the assumptions he makes. As one example, he's an economist, I'm just a doctor. He says a year of extra life is $100,000 in value. I mean, a year of life to my daughter would be worth to me much more than $100,000. But he's an economist. He comes up with numbers for things. He has pointed out, as you know, historically, cardiac care has actually risen in terms of cost, but outcomes are better. Cardiac death has fallen by 2/3. But the funny thing is, if you go back and reanalyze this data, since 1996, health outcomes actually haven't improved, and yet costs have continued to rise. So actually unit costs in healthcare continue to rise. It's one of the problems employers have. We've talked unit cost in terms of service. Certainly that would be true also in terms of unit cost of health insurance premiums. As you know, since 2000, costs have roughly doubled to employers across America. So we're seeing this strange effect where with agriculture, with clothing, with shelter, one finds costs, relatively speaking, to GDP fall over time.
I'd like to thank the Manhattan Institute and the Hastings Center for sponsoring this event. And please thank our panelists and yourselves for coming. Thank you very much. And that's it for tonight's show. We hope you got something out of that debate on health insurance in America. Next week, we'll be back to our regular live format. And don't forget to join me on my weekday radio show on WNYC New York Public Radio tomorrow morning at 10 o'clock on 93.9 and AM 820 WNYC. Have a great night.
One of the things